This episode of GT the Podcast is sponsored by Alcon Global Medical Affairs.
Hey everybody, welcome to a special edition of Glaucoma Today, the podcast. My name is Paul Singh. I'm a glaucoma anterior segment surgeon out in southeastern Wisconsin, and I'm honored and privileged to be hanging out with two fantastic surgeons and educators. Christine Funke from Phoenix, Arizona. What's up, Christine?
Hey there, how are you?
Awesome, doing well. Looking forward to a fun discussion. And of course, we have Pradeep Ramulu from Baltimore, Maryland at Wilmer. What's up, bud?
Hey Paul, how are you? Christine, how are you?
Hello, great.
We're really pumped, you guys. So today we're going to talk about the Hydrus Microstent and the Horizon trial with some of the best data we have in the MIGS world. And so we're going to kind of have a real life discussion. The idea today is, we're going to talk about data, of course, and data is important, no doubt. But really, what more important thing is just talk about real life. What do we do in practice? MIGS has gone through an evolution over the last decade now, being approved over in 2012 in terms of the first stenting that we had available, and now we have the Horizon trial showing us great data for the Hydrus and other MIGS procedures. So, kind of want to talk about in context of MIGS today, kind of where we're at, where we use the Hydrus, how does the data help us understand where the Hydrus fits and how we judge, and maybe how do we decide what is truly kind of successful in our practice. And so that's the idea today as well. So I kind of want to start us off by just asking you guys before we start in general. Are you guys using the Hydrus a lot in your practice? Christine, tell me about your practice and how you utilize the Hydrus overall.
Sure. So my practice, I am seeing probably about 90% glaucoma. And of that, I think over the last several years, as minimally invasives have become more of a standard of care, I would say of my cataract surgeries, I think probably about 80% are getting some form of minimally invasive with them. And of that, a lot of them are getting a Hydrus as part of that package. So it's become a mainstay, I think, of a lot of what I'm doing at this point, especially in conjunction with cataract surgery.
No, absolutely. Pradeep, of course, love to hear your thoughts on how you use the Hydrus, but, in general, talk about MIGS combination cataract. And is there a reason if to not do a MIGS during cataract surgery? Love to hear your thoughts on that.
Yeah, Paul, I think it's really been, kind of analogous to discussing lens choices in the setting of cataract surgery. You really have to bring up, a toric if somebody's got an astigmatism, a multifocal, assuming that they don't have, moderate to severe glaucoma, and I think it's really the same thing has happened in glaucoma, where if somebody is on drops, is on therapy, and you think they need therapy, you really have to discuss this option with your patients. And I think if discussed in an honest way, in an open way, including the risks and benefits of the procedure, the large majority of patients will want to have it. When the indication is appropriate. Like Christine, almost all my practice is glaucoma. But anybody who's on a medication is usually getting some sort of MIGS procedure. And if they're an open angle, I like to use the device that has the greatest evidence behind it. And I just love the 5-year data from Hydrus that really shows that this procedure works over a very long period of time. And our patients, we don't know how long they're going to live, but a lot of them live with the disease for 10, 20 years from the time of their cataract surgery. And so it's nice to know that we can cover, potentially a big portion of that with the procedure.
Yeah, man, you made some good points there. We talk about the fact, we're going to talk about success and what does it mean to get off of medications. The data shows us that we have a better chance, hopefully, of getting people off of medications after stenting with a Hydrus versus cataract surgery alone. But, I want to talk to you about a couple of things first, because to me, what MIGS has done has really got us thinking again about mechanism of action, right? Before we had MIGS, it was, basically drops. And we talked about mechanism of action with drops, but it was then just do trab or tube or something like that. And we didn't really care about mechanism because we knew what was happening, right? But now with MIGS, we're talking about where the resistance is. Talk about that, Christine, about us not preoperatively, not knowing where the resistance is to outflow. Is it TM? Is it the canal collapse? Is it the distal collector channels? And how maybe the Hydrus and the trimodal mechanism of action, how that makes a difference theoretically to you. Talk about that for me, if you don't mind.
No, I actually think that's one of the big positives of this minimally invasive compared to other things out there. And like you said, you don't know where you're having the resistance. And so with that, if I can hit as many different points of the potential resistance, the happier I'm going to be. And most likely, I would assume also my outcomes are going to be that much better. So when we talk about Hydrus, What makes it different is that we are working on several different places, like you alluded to, including we're having a larger pore size to get entrance into the actual canal. And then you have these eyelets that are going to open or stent open the canal that could potentially be herniated. So we know that I am hitting multiple collector channels with one single device. And that means a lot to me as well, because I know I'm going to have a better chance of hitting the right spots by using this device, as opposed to kind of guessing based on what the anatomy looks like.
No, that's a great summary. And, Pradeep, taking to what Christine said, talk to me about, like, just to remind everybody, the Hydrus, what it's doing, this whole idea of trimodal mechanism. What does that mean exactly? And kind of this whole scaffolding. Can you talk more about the stent itself, how long it is, and what she means by, accessing multiple collector channels?
Yeah, I think that it really, first of all, it's bypassing the trabecular meshwork. Is creating a fistula between the anterior chamber and Schlemm's canal. And, it's also stenting things open. So, opening up that canal. And as Christine was mentioning, it does it over a long period of time. And it does it with a very kind of clever design where, really most of the scaffolding is on the internal side. So on the side facing the trabecular meshwork. So it's really kind of opening and leaving open that area to the collector channels. And it's doing it over a large enough period of time that it really should, expose that aqueous to numerous collector channels. And so it really gives you more confidence mechanistically that this is something that's likely to work.
Yeah, and I love the fact that it's minimally destructive to the target tissues. We talk about MIGS being minimally destructive. I mean, really, you're keeping a lot of the natural TM available. You're just going through a small portion of TM to get that into the canal. And people talk about the length of the stent, being 8 millimeters long, and is that an issue? Talk about that, Christine. The fact that it's in the canal, not exposed to the anterior chamber, and how, from a comfort level, do you feel safe to safety and et cetera from a surgeon perspective?
I have to back up because I feel like you hit the heartstrings that I have about sparing tissue.
Yeah, please. This is open. Yeah, talk about that.
Yeah, tissue sparing has just been something that I've been really passionate about for a long time. And this is something that we are doing tissue sparing surgery. I know there's a lot of different options out there, but I find that I like SLT. So I like to back up and say I love SLT. I love SLT first line. And when I'm doing minimally invasives, I don't want to limit myself later. And I know that just like everything else in glaucoma, it has a limited time, right? That it's going to be functioning for me. So if I can save room for something else later, especially something minimal like SLT, or who knows what else is coming down the line with minimally invasives, the better. So when we talk about Hydrus, one other thing that I love about it is just that it's tissue sparing. And that means that it's sparing me my own personal trauma later when I have to tell a patient that they need another surgery, because I still have a lot of options. But also in terms of safety, having this, not very much of this in the AC, is probably something that's nice. I was a big SiPass user in the past. And so with that, we got hit with endothelial cell loss and we lost that device. But when it comes to this device, I feel safe around where it's sitting, with most of it being tucked away. So I think it gives me comfort, and it also gives patients comfort that this is something that they're never going to know is even there.
Yeah, I mean, but 90% of it's is actually in the canal. Not a lot of it's exposed in the AC, and it's exposed parallel to the TM versus pointing back up at you towards the AC. So it's nice from a kind of contour. It's a nitinol material, which is also very flexible, follows the contour of the eye very nicely as well. But talk about that, Pradeep, a little bit about what Christine was saying about kind of verifying the placement, how it's in the right place. So from a surgeon perspective, talk about the learning curve and a little bit about how to place it and some pearls as well, because that's something that I think people talk about a lot. Being larger, they get a little fearful, but I think it's truly intuitive. So talk about that.
Yeah, I mean, I've kind of lost track of what fellow number I'm on in terms of having taught this, but it's probably it's in the double digits. Everybody's gotten it. It didn't. I think they end up leaving here, doing probably triple digits of them, but it doesn't take triple digits to learn the procedure. So they're getting it by the 10th procedure, often earlier. But I think first thing I'm going to mention, which you guys can elucidate on, is really visualization. If you're not looking at what you're supposed to be looking at, you're going to have a hard time getting it in. So you have to be comfortable in the angle, and before you step into this, just make sure you're comfortable with your intraoperative gonioscopy. You may want to do some gonioscopy on just some regular phacos. So I think I can leave it to you and Christine to talk about some of the tips.
Yeah, Christine. I mean, I know we've been harping on this for 10 years now about visualization, but I still think it's still like the crucial part of any MIGS procedure. I don't care if it's Hydrus or something else. It's just getting a good view, number one, making sure you have an en-face view, right? The TM facing you. But talk about a couple things. Talk about some pearls and how to maintain or how to get a good view, but also maybe some Hydrus pearls, maybe incision placement, kind of angulation, things like that, and what to watch out for.
Absolutely. I feel like view is 90% of this procedure. As with like all minimally invasives, if I don't have a good view, or if my view isn't on FOSS, like you said, if I'm not getting a great view of that TM and into the spur, I have to reposition before I'll even go forward, because I know I'm going to make my work harder than it really needs to be. Once I have a good view and good position, I feel like usually the rest is a pretty easy go. In terms of pearls, of what I tell people when I'm teaching them what I'm doing and how I have the success I have with this device. And again, I think it's pretty intuitive. I like to use a lot of OVD to really open up the angle. I turn the head quite a bit so that, again, I almost feel like I'm getting to a point where you almost feel as if you can start to see the angle without the gonio prism. Now, of course you can't, but it's almost turned to that position. And then for my hand positions, I actually do my phaco wound to the side. So I make my main stab and my secondary wound kind of like a pie piece, where my main wound is to my right. And so I already have the angle that I need in order to get access to have a good flat entrance with the Hydrus. I know also a lot of people will make another incision, which I also think is great. But I think the main goal for whatever incision you're going through is making sure that the cannula is flat up against TM. If you have a flat cannula and you can just roll right in, I think that's helpful. I think you're going to go in the right trajectory of where that canal is running. Because again, like we've talked about, this device is already made to fit inside of that area naturally. I also like to score a little bit. I think my first minimally invasives that I started doing, aside from iStent, was iTrack. And so I had to make a small goniotomy. So maybe that's just now like my go-to, but I make a small goniotomy. It gives me a little better visualization, especially in people who don't have much pigment in their drainage structures. I think that's really helpful when you're first learning too, because when you open up underneath the TM, you'll see the shine of the back part of the canal. And so you really know you're in the right spot, and then go for it. And I would say 95% of the time, if you've got a good view, your hand's in the right place, and you know you're in the right spot, you're going to have a very easy delivery.
Yeah, I mean, I think you made some really good points. I think that's that incision placement of that, where the Hydrus goes through, it's about 3 clock hours away from the intended site of insertion, whether it's your main incision or another paracentesis, is so crucial. Don't skip on that step. I think it's really important. No. And keeping a steady hand position, I aim a little bit upward, maybe 15 degrees upward towards the TM. And you don't have to push very hard. I think one thing I've found is that I know scoring is great. Or if you don't score, just don't push so hard where it gets buried in there, because then you'll hit the scleral wall. So that's a small nuances. But really, once you get the hang of it, it should go in like butter, right? I mean, you really shouldn't feel pain or resistance. If you feel resistance, that's a sign, right? You might be in another spot. So how do you know if you're in a superstoric space? Well, you just retract it back, and they'll feel discomfort. You know you're in the wrong space. But when it's in the right space, it goes in beautifully, and you see those windows go in there nicely as well. So open up the clamshell, and I just kind of open it up, and then I kind of remove it circumferentially so I don't pull on the actual inlet itself as well. Sometimes you have to reposition it. You have the ease of retracting it back. And if you place it, you don't like it, you can use that loader to just kind of retract it right back into the loader really, really simply, which I think is fantastic. And you can change hand positions. You can make another incision if you have to. So it gives you a lot of flexibility. So great pearls there, Christine. Let's talk about success as well. I mean, we think about like success, not just at 3 months, at 6 months, but, kind of 1 year, 2 years as well. And, I want to get your thoughts when you define success. And we're going to go through the Horizon trial in a second, and the 5-year data as well as 2 and 5 year. But, I just want to just kind of talk about, cataract surgery. There's been this kind of still this narrative that, cataract surgery does enough to kind of get the pressures down. So really, why do we have to do MIGS? And, we do know that it works, but, Pradeep, talk about kind of how long cataract surgery lasts, some of the data out there as well, and maybe consider like the Hydrus, and what does it mean after not just 6 months, but 1 year, 2 years, and beyond?
Yeah, I mean, I think that the FDA did a really good job of really kind of putting it out there about how we should test the efficacy of these devices. So there was really a very strict and somewhat onerous protocol, but at the end of the day, it really taught us, how much is actually happening from the device and how much is happening from the cataract surgery alone. So just to remind everybody, they required they required a washout at baseline. So they had everybody's baseline IOP, and then they washed people out again in these postoperative periods. And so, when you actually look at the washed out diurnal IOP and compare that between the eyes that had cataract surgery with the Hydrus and cataract surgery alone, you can see that you're retaining the effect of IOP lowering in the Hydrus group, and it's starting to wear off in the cataract group. Probably the best one is the OATS data, where they really had many time points of IOP measurement before and after cataract surgery. And they found the same thing, that you got a pretty decent amount of IOP lowering, maybe about 15%, 16%, but it started wearing off, and by 3 years it really had dropped to less than 10%. So I think that this goes along with what we know about cataract surgery IOP lowering from other sources, that really most of it is for the first year or two, and it's starting to go away, and probably by about 3 or 4 years there's not very much of an effect left. And so the stent is, when you start getting to those later time points, is really probably carrying most of the load, as you said, Paul.
Yeah, and I think that's a key, right, Christine? I mean, we tend to think of glaucoma a lot of times that, oh, look, it's 6 months later, look at how good we did. But, we got to think long term. And, does a year, 2 or 3 make a difference in terms of just this longevity of these procedures compared to, let's say, cataract surgery alone? Let's say it only lasts another 2 or 3 years more. Is that important, by the way?
I think that's important to our patients, and it's probably very important to us too, right? I think the goal for all of us, especially in the world of being glaucoma surgeons, is we're just trying to prolong keeping vision around, right? That's always the goal. So to have 5-year data to talk about is awesome. I mean, it gives them extra confidence that what I'm doing is scientifically based and that I know what I'm talking about. And that gives them a lot of confidence to move forward with what we're doing in the operating room together.
Well, great discussion. I think we kind of, discussed the mechanism of action and the importance of kind of just trimodal mechanism of action as well, and then really trying to get people, hopefully, off of some medications. Let's talk about the data that supports that and really the efficacy. And, Christine, talk about the kind of impact of the Horizon trial and you clinically, and kind of why that data set is so impactful and kind of so robust.
Yeah, it was actually when the 5-year data came out, I think is when I really started to change how I was using Hydrus. Initially, I started using it kind of in lieu of CyPass as kind of my more moderate to angling towards severe patients. And then when the 5-year data came out, that changed everything for me, because there was finally data to support that there was something that was going to have more longevity. And that was when I started to use this on my single med mild patients. And so I think that's where, for me, Horizon kind of was like a light bulb, was that this is something that can be used in a broad way and didn't need to be singled or pigeonholed into a certain category of patients, but actually had a large benefit in terms of the breadth of my glaucoma clinic.
You're absolutely right. I mean, I think we kind of pigeonholed it initially. It was like, okay, it has some of the best data, so I'm going to use it for my moderate patients on 3 meds. But you realize that the safety, as we'll talk about, is really overall very positive. Also, that, hey, why not that 1 med patient, who's doing cataract surgery, that mild patient at 1 med? So let's definitely want to kind of talk about that too some more, because it's a really good point you brought up as well. In terms of design, Pradeep, the Horizon trial, talk about the 5-year planned follow-up. What does that mean to you? Because that was really something I think was really, to me, really impactful. Talk about that.
Yeah, well, I think that the manufacturers and those who designed the trial and carried it out really need to be given a lot of credit. They really wanted to follow this out for a long time. They kept people in the trial. That 80% of people were still in the trial after 5 years, which is a very difficult thing to do, to really keep people engaged and coming back and making sure they're not lost to follow-up, which could introduce some bias into the trial. And to have that data going so far out is exactly what Christine said. You can tell patients more confidently that this is a procedure that's likely going to last for a considerable amount of your disease. I agree with Christine also. There's kind of this notion out there that, well, this is a bigger device, so you should save it for battered glaucoma. But that logic doesn't really fit. You want the device that has the best data. Even if you have early glaucoma, why does that mean that it's only reserved for like more severe glaucoma? So, for me, my cutoff is they're on therapy. If they're controlled and they're on therapy, it's a great indication.
Yeah, I mean, you made a good point. But yeah, I mean, the study, as you mentioned, 5-year planned 5-year follow-up is really important in multiple countries around the world as well. So pretty impressive data set out there. So in general, talk about what medication burden reduction means to you again, and how that defines success. So we mentioned earlier, and Christine, you mentioned how you can tell your patients that you have a better chance of being off of medications. This is at the 2-year and the 5-year mark, more than cataract surgery alone. But when you define success, how do you define success? Is it IOP reduction, 20% reduction, which you see more in the cataract surgery? Is it medication burden reduction? Is it both? Talk about that.
I think we've been able to change our perspective on what success is as we've gotten more deep into how we're using MIGS and how we've had a lot more options. For me personally, at this point, I've defined success for the majority of my patients of getting them off as many medications as possible. And I think we underplay a lot of times how much of a burden that is to people, medications. I had a patient today who's an awesome example that I hear more than maybe we should, who just said, I changed her whole life because her eyes don't hurt anymore and she's not red, and she didn't know for 5 years why she was so miserable. And she went to 4 different doctors and no one could figure it out, right? So she had allergies to bromonidine. She was a mess when I first met her. And so the fact that I could offer her something different, something that is low risk, high yield, and that ultimately she can successfully feel like she can function in her life better, I mean, that's massively successful both to her and to me. And so for me, success is becoming more about patient quality of life, and then also, of course, stabilizing this disease. And so I guess that's where I've come to defining minimally invasive success at this point.
Yeah, I mean, I think, to me, this whole what's changed so much philosophically for me, this whole interventional mindset we have now, is not having to choose anymore like we used to between controlling glaucoma, being aggressive with IOP reduction, and dealing with compliance, and saying, oh, well, can I also maintain high quality life at the same time? It's either one of the right? And now we actually can do both, which I think is really impressive as well. And so I think for me, Pradeep, how impactful, I mean, how much of an issue do you think compliance is in your practice? Whether it's ocular surface disease, forgetfulness, cost, all those things. I mean, how much of an impact do you think it has on your patients' compliance in general, poor compliance?
Well, it's always out there, Paul. I think that, we've done studies at Wilmer and others have done it as well, that, you ask people, how often are you taking the drop? And they tell you 100%, and they're taking 70% of the drops. And, that's the average of people who are coming to an academic institute, to get their care. So it's hard, it's hard to remember to do something every day. And, I think we can all acknowledge that ourselves. So, I think that it's not just, to take that off their plate is beneficial in a lot of ways. There's certainly strong evidence from SIGITs and other studies that compliance matters in terms of your visual outcomes. I think what Christine said is absolutely correct, that a lot of our patients have some degree of ocular surface disease. But I think there's just the other thing that I always mention, and not that this is the biggest deal in the world, but every time you pick up that drop, you kind of remember that you have a problem, that you have a disease. When you take people off that drop altogether, it's almost that like it kind of like leaves their psyche, except when they come to see you. And so it's really nice to give people that freedom.
Yeah, I mean, I totally agree. I mean, and I think we kind of minimize the impact of drops on the ocular surface, but also on their quality of life and their psyche, like you just mentioned. Really good point there as well. And for me, I think that what's so frustrating is sometimes not knowing why, like you said earlier, why some people get worse. That's the whole question. Do we have to get lower pressures, or is it just minimizing fluctuation? I mean, and that we don't know, of course, 100%. But as you mentioned, there's other studies, Aegis has shown that, and others, the more advanced you get, of course, the more we see that visual field progression is worse when you have more fluctuation. And so I do think that, earlier trials sometimes don't show the fluctuation showing as much of an impact because we're looking at visual fields. And early on, you may not see the function change as much as structure, but no doubt that insecurity, unknown of what is a relative contribution of poor compliance to someone progressing is frustrating. So for me personally, I trust someone with a Hydrus having 2 millimeter mercury higher pressures than when they were on meds. We look at the data from 2 to 3 to 4 to 5 years, you consistently see that more patients who are off of medications in the Hydrus versus the cataract surgery alone group, and you see still that maintained efficacy, about a point and a half better reduction over time between cataract surgery alone and the Hydrus. Christine, I got to ask you a question. So we talked about efficacy. We know it works. We know it lasts. 5-year data shows that it has safety and efficacy with being off of meds as well as IOP reduction. But talk about safety and talk about kind of secondary interventions. one of the surrogates for me for is something really working is, are they getting worse and do they need a secondary surgery? So talk about what the Horizon 5-year data showed us in terms of people who needed secondary interventional surgeries.
So this is another exciting point to talk about when we talk about minimally invasives, especially as glaucoma surgeons, right? We want to try and avoid trabs and tubes as much as possible. Talk about chair time and hand holding for the rest of your life. These patients, we marry them. So minimally invasives have honestly changed how my practice looks. My OR has switched from having more trabs and tubes to a lot fewer, not none. I don't know if we'll ever be lucky enough to get rid of those procedures completely. But the data around Horizon really supported that, which was there was a shift in the amount of secondary incisionals that needed to be done after patients had a hydrus versus those who had cataract surgery alone. And so sometimes I think this gets overlooked too by our incredible cataract colleagues, because they don't have to take care of these patients when something doesn't work, right? That's us. And so it's so nice, and it continues to be so important to talk about minimally invasives and the importance of them so that we can avoid these bigger, more potentially detrimental procedures to patients. And so for me, this is a nice take-home point for everyone, that we can avoid trabs and tubes more often if we're using minimally invasives.
No, I think that's important to recognize as well. And the earlier we address the disease, the higher the target pressures are, and that's usually right. And the better chance for a lot of these conventional outflow MIGS are going to achieve that target pressure. So that's why it's so important to do it, to me, as early as possible. But you need to have good safety, right? To do it earlier when you have someone who has healthier nerves and healthier younger patients, a lot of times we want to make sure safety is good. So Pradeep, talk about the safety. I mean, and we talk about how it's a longer stent and it's mostly in the canal. But just talk about the kind of safety from 2 to 5 years and how we didn't really see much of a difference. Talk more about that if you don't mind.
Yeah, the endothelial cell loss is no different between the two groups. The device explant or serious complications from it are very, very rare. I probably put in about 400 or 500 of these. I did have to remove one of them because it was kind of sticking back into the anterior chamber. So when you put them in, make sure you kind of gonio a little bit to the left and see the distal tip of it. But it's I tell people, and it's still true, is that I haven't had anybody who was seeing worse than their baseline vision 2 weeks out from surgery. So and I put in hundreds of these things, and so I can tell people that this does not affect your vision. It's really not a vision threatening procedure. Not that it can't cause problems. You got to be careful. You got to be ready for you got to be ready for things that are rare. But it's a very, very safe procedure, and you're not really kind of looking at some of the severe complications that we see with a lot of our other more traditional surgeries.
Yeah, and I think people worry about things like PAS getting worse, scarring getting worse. I mean, Christine, did you find that? I mean, in the studies and clinically, do you find there's a big progression in terms of issues from 1 year to 3 years or 5 years, et cetera?
No, not really. I like to gonio every once in a while and just peek at the hydrus and see what's happening. And most of the time, not much is happening. Very rarely have I found somebody who I am finding some PAS. And if I dig deep enough, usually there's some underlying autoimmune something that they forgot to mention. So I have had that a time or two. But for the most part, it's not something that would prevent me from using this device on pretty much any open angle patient.
Yeah, I think it's important, with the studies from the Horizon, they didn't really see a significant difference in safety between 2 to 5 years. So that long-term safety, I think, and no additional issues that we found was really important. And then a lot of times, we look at PAS, if you see ungonius and PAS, and it may be, even if it's partially obstructed the inlet, usually if you look at the data and the studies, we didn't see a significant issue with IOP. As long as there's a small opening still there, even if you have a little PAS there, it hasn't seemed to be an issue in terms of IOP control. So I think that's important as well in terms of inflammation. We don't see that as an issue. And you mentioned ECD. I think that's important. That the CyPass, as you mentioned, Christine, was something that got us all worried about. Long-term data, I think having 5-year data showing that pretty consistent ECD is pretty important. I mean, do you guys think about that with your patients at all anymore? I mean, is that something that crosses your mind? I mean, with the hydrus, I don't even think of it at all now. Do you?
No worries.
No worries.
Yeah, I agree. I think that's an important concept as well. So as long as they have open angles, I think that's really important as well. So knowing that there was no in the studies of 5-year data, no serious complications or decompensation, with ECL issues at all is really important. So I think in a nutshell, I'd love to just get your thoughts in general. I mean, so if you had to summarize the typical hydrus patient, Just give some pearls on how to select it, how to talk to patients about it. Christine, what do you think?
I think in terms of what patients I'm looking for, or anybody who's getting cataract surgery, unless, like we talked about, there's some kind of other angle issue. If it's an open angle patient, whether it's mild or moderate, I'm discussing this device with them. I think that they're all good candidates at this point. We've got enough data to support all of that. And so again, I'm pretty broad with how often I'm using this device at this point, because I've been very happy with the outcomes.
And Pradeep, how do you manage expectations? I mean, that's a fear I think from some surgeons too as well. Like, hey, what if it doesn't work, or what if I don't, they have to have a surgery someday. How do you manage the expectations before surgery for that patient?
Yeah, no, it's a great point, Paul. I mean, we always have to remember that all these advantages that we're seeing are in the aggregate. So, you can tell people that, look, on average, people are on fewer medicines. Many of them are on, their pressure will sometimes be a little bit lower. Some people will avoid surgery, but, we don't really know for sure. And we can't guarantee that you're going to be in all those good outcomes. And so, don't be surprised if you end up on a medicine or two. It's even possible that sometime in the future you may need surgery. I mean, all these things are going to be less likely, if we put the stent in you, but we can't guarantee that, that's going to happen.
Yeah, I mean, it's really good points. And I think it's important to recognize or tell patients, look, this is a journey, and I'm with you in this journey for you until you leave, right? And the bottom line is we have multiple options for you, but I'm going to pick for me, what I think is going to give you the best chance of keeping the highest quality life, the safest way possible. And guess what? If it doesn't work, or if it ends up not working over time, we have other options. And so as long as we understand that going forward, we have options. This is something I think would be the best for you at this time during cataract surgery. So I think you're absolutely right. Making sure that patients are aware of that. Not everyone will have the same success, but they understand that ahead of time and know there's other options going forward, and we may have to change things later on. That to me is important. So this journey idea, and that there's multiple options over time. Well, we talked about some pretty cool stuff. We talked about implantation and mechanism of action, the 2 and 5 year data on efficacy, as well as medication burden reduction and safety. But I think at the end of the day, what we worry about is progression in terms of visual field, right? That's how we kind of monitor our patients a lot of times. And so, during the Horizon trial, the 5 year data, they actually went ahead and said, okay, let's do a post hoc analysis. Let's look at the visual fields, because visual fields were measured by different time points. So they went back and looked at the visual fields that were collected during the Horizon trial and did a post hoc analysis to see and explore, what was the visual field progression and rates between the cataract surgery alone group as well as the Hydrus cataract group as well. So just to remind everybody, in the Horizon trial, they measured visual fields preoperatively as well at 6, 12, 24, 36, 48, and 60 months. We had a number of time points for visual fields that were collected as well. Now, again, this wasn't a planned outcome. This is a post hoc analysis as well, but we looked at the data that was obtained in the Horizon trial as well. And it's just important to recognize when you look at the global indices of the mean deviation, the pattern standard deviation, looking at 2 and 5 years, there was no significant difference between the two groups, between the Hydrus and the cataract surgery alone group, looking at those global indices as well. This post hoc analysis was done at more fields, and they basically looked at point by point as well as kind of put them in clusters in the visual field, and there's different areas, and so they were able to kind of look and see, okay, what area maybe progress more rapidly. But if you look in kind of more detail, looking at kind of progression, rates of progression, et cetera, there was a difference. So I'm going to actually, Pradeep, ask you, when we look at rates of progression between the cataract surgery arm and Hydrus arm, was there a difference? And what does that mean to you? Talk a little bit about the differences between the two groups when you look at rate of progression.
Yeah. So, I mean, this is we all have to keep in mind, first of all, Paul, this is this is a post hoc analysis. And so, we don't want to, kind of take this as the primary reason to do the stent. But certainly it's encouraging that, there's some evidence that, perhaps this is not only a procedure which helps people get off medicines and helps them, keep the pressure low. This was, a point-wise analysis. And so, when we're talking about 0.49 decibels per year, we're not necessarily talking about the mean deviation. We're just talking about the point-wise sensitivities. But nonetheless, you're seeing that, overall that, points are generally doing a little bit better in the microstent arm. This is something which is, at least on average, for the person who has the average effect, is probably not going to be the difference between driving or not driving, or reading or not reading.
Yeah, I mean, just to remind everybody, so the rate of progression in the cataract surgery arm, alone arm, was about minus 0.49 decibels per year, and the rate of progression in the cataract Hydrus arm was negative 0.26 decibels per year. So there's a difference that way. But to your point, Pradeep, they're definitely, you have to take it in consideration. This wasn't a primary endpoint for them as well. And if you look at that, all clusters in the cataract surgery arm kind of displayed a larger rate of progression compared to the Hydrus, and the location and the clusters with the fastest rate of progression were seen in the cataract surgery arm. But Christine, I want to get your thoughts on what does that mean to you? I mean, so Pradeep was mentioning how, maybe a little bit of good, we're helping patients. But, is 0.4 decibels or 0.2 decibels per year significant? Maybe at 1 year, 5 years, who knows? But what does that mean to you personally?
I think that this just helps us kind of ask the next set of questions, right? Of what are minimally invasives doing compared to other ways that we're treating glaucoma? And is that changing the rate of progression? So I think this, again, could this be buried in bias, or could there be something more to it? And I don't think we can completely answer it purely based on the post hoc analysis, but I think it's a really good stepping stone to start saying this is really important to us, and it's something that we need to start watching more. The other thing that was interesting when looking at the post hoc analysis is that there was actually this subset of individuals that were progressing at a faster rate. And those patients, or this cluster of individuals, was found more prominently in the cataract surgery alone group, as compared to when you're looking at the cataract with the Hydrus group. So again, what does that tell us? Could it be potentially that they got randomized into a specific location? We have these fast progressors that just randomly got put into the cataract surgery alone group? Potentially. Could this also potentially tell us that there's fast progressors generally that we don't detect well, and that they tend to do better or slow down their disease with the addition of a minimally invasive, potentially? And if that is the case, that could be substantial for us, that we could be catching or slowing down those patients who, for me, I think I probably lose the most sleep over, because those are the ones that they're losing at a faster rate with the disease. And again, we don't know. Going into the operating room, you can't look at their eye or look at their history and know who that person's going to be. So again, I think it's bringing up a lot more questions that we want to continue to look for answers on in order to better treat patients.
Yeah, no, really good points as well. I'm just going to make sure we clarify a few things. Those clusters, it was called the Garway heat clusters. Those are basically the approximation of the location of where the nerve fiber layers are, and that's how they were able to see, okay, here's where the visual field clusters are and how they relate to where the nerve fiber layer kind of exits the nerve. These are, again, mild to moderate patients, so we don't know what happens in more advanced patients as well. And we also got to make sure that, we don't know the clinical relevance. So I want to make sure that's clear as well. And we don't know if the fast progressors in the cataract surgery arm group was the reason why we saw the differences. Again, just to be clear, a lot more to have to still figure out.
It is a fascinating thing, and something that we see in the light trial as well is that these differences in progression seem to be independent of IOP, and so kind of we don't really know why that is for sure. We don't know whether, but it kind of does lay out this idea that maybe the pressures that we're measuring in the clinic are not all the story. Is it compliance? Is it a fluctuation in IOP? And so I think that there's more work to be done about, whether Hydrus and SLT and other treatments may have a benefit for pressure outside of the way that we're traditionally measuring it.
Absolutely, absolutely. This is kind of why, as I mentioned earlier, I have so much more confidence. This is my personal opinion, but I have more confidence in a person's pressure, after not having to worry about drops and the potential for fluctuation, the potential for peaks and troughs and non-compliance and all that good stuff as well. So that it kind of all helps kind of align with that thought process, at least for me personally. Again, thank you guys. That was a great discussion, and hopefully it helped you guys out there as well. But hey, guys, this was a lot of fun. You guys were awesome. It was so much fun to learn from you and all the pearls. I know we already probably are a little bit longer than we probably wanted to, but it was such a great discussion. So I just want to thank you all for joining us today. I appreciate that, and hopefully this was informative for you. Thanks to Christine and Pradeep, and hopefully we'll keep in touch and hope this helped. Take care, everybody. Thanks so much again.
Thank you for tuning into this episode of GT the Podcast. If you have any feedback or topic suggestions, find us on Instagram, LinkedIn, Facebook, or Twitter. And stay tuned for more hot topics in glaucoma care on GT the Podcast.